Hello, good morning all of you. This is a small presentation of a problem in the left hip joint. A 17-year-old girl comes to us with pain in the left hip joint for the past 9 years. In the past, when she was 8 years old, she underwent some surgery for a floating knee. They must have put 10 nails for femur as well as tibia. You can see them in this scanogram. Here the trochanter is almost at the level of anterior superior iliac spine. When we observe her gait, she has got an antalgic gait, walks very carefully with a short limb component also. To our surprise, when you have done the Trendelenburg sign, when the patient is standing on the diseased limb, she is able to use her abductor mechanism to raise the opposite pelvis. That means there is the reasonable function of the abduction mechanism on the diseased side. We have also taken the CT scan of the patient. Based on the scanogram, we realized that both limbs are parallel to each other, where both knees are at the same level, and there is pelvic obliquity to compensate the shortening of the limb on the left side. The trochanter is almost at the level of anterior superior iliac spine. We can make a diagnosis of a non-union of intercapsular fracture neck of the femur of 9-year-old duration. Since it is a very painful hip joint, we just wanted to examine the hip joint under a C-arm without anesthesia, where we can find some amount of movement of the trochanter. The trochanter is at the level of just above the acetabulum with good neck shaft angle maintenance. I just want to emphasize here the viability of the head, wherein we take into consideration of the congruity of the head. The head is very much congruous. That means the head is able to tolerate the weight of the body for the past 9 years, even though there is a non-union. And then radial density of the head, when compared to the neighboring bones, it has the same radial density when compared to the neighboring bones. So under anesthesia, not on a fracture table, we could get down the trochanter as much as possible to the level of the superior part of the acetabulum with maintenance of good neck shaft angle. The plan was to do valgus closed osteotomy at the intertrochanteric level. I am trying to explain that in an animation. We pass a guide wire to accommodate the derotation screw to prevent the rotation of the proximal fragment. The non-union is stabilized again by a dynamic hip screw. Once a dynamic hip screw is done, we do a valgus osteotomy, closing valgus osteotomy at the level of lesser trochanter, and then stabilize that with a dynamic hip screw system. Once that is done, we bring the limb to neutral position and then realize that the shearing forces, they get converted into compression forces. This is the plan we are going to do. Under anesthesia, on a fracture table, you could get the detection of the fracture even though there is a gap in the non-union site, both AP and lateral views. We try to pass a guide wire for the derotation screw to start with. As we are passing guide wire, we could see that the gap getting narrowed at the fracture site or non-union site. Once you fix the fracture with the derotation screw as well as with the dynamic compression screw, the gap gets narrowed and then the fracture is stabilized, the non-union site is stabilized. We do not open the capsule in this procedure at all. Later on, we have done is intertrochanteric valgus closing osteotomy and then stabilize the osteotomy as well as the gap non-union. The immediate postoperative picture shows there's a good fixation of the osteotomy as well as the non-union site, both AP and lateral view. You can realize that the obliquity of the pelvis has disappeared. We followed the patient for 3 months' time, wherein we can see the consolidation of the osteotomy site as well as the intercapsular non-union site. Even though the head is little outside the acetabulum, Patient is asymptomatic at this point of time. The patient has no limb-length disturbance as evident in the pictures, both in flexion as well as extension of knee joint and at the level of feet. The integrity of joint is well maintained as evident by the good abduction and external wherein the patient is comfortably squatting with crossed legs. The patient is followed for 8 months time, and the radiograph of the 8 months postoperative period shows good union of the fracture as well as the osteotomy site as evident in both AP and lateral views. We just wanted to compare these radiographs with the scanogram and noted that there is a disappearance of the obliquity of the pelvis and the trochanter has come down to normal level, giving rise to a stable, painless gait for the patient. The take-home message is that valgus osteotomy for non-union intercapsular fracture is a good procedure, even though the duration is of 9 years, particularly in this case. Thank you very much and best wishes to you all.